are Sint Maarten. You are Sint Maarten.
The URSM, the Unified Resilient Sint Maarten Movement, being a political movement, will be hosting a weekly radio program called You Are Sint Maarten, every Wednesday from 6 to 7 p.m. on Radio Mix 94.7 FM. I myself, Dr. Messalina, the political leader of URSM, will be hosting this radio program in which current issues, actualities and general topics will be discussed with the people of Sint Maarten. So join us every Wednesday on Radio Mix 94.7 for our radio show You Are Sint Maarten.
You are Sint Maarten. You are Sint Maarten.
Dear people of Sint Maarten, good evening. Welcome to your weekly radio program You Are Sint Maarten on Radio Mix 94.7 FM. I myself, Dr. Messalina, the surgeon in Sint Maarten Medical Center, will be, as usual, your host in this radio program. As you know, next of being only the surgeon of Sint Maarten, I'm the political leader of the URSM, the Unified Resilient Sint Maarten Movement that will contest the upcoming parliamentary elections for country Sint Maarten, with, of course, my political movement, URSM, Unified Resilient Sint Maarten Movement. As you know, URSM stands for putting the people and the country above self and beliefs, of course, and informing and educating the people of this country. We strongly believe that there should be a sound balance between economic growth in a country and the welfare status of the people. We are presenting a weekly program in which current topics, community developments, and issues and general matters concerning the people of this country are discussed. As I said, the URSM is a new political movement and would like to, of course, add some great development to country Sint Maarten. And as you know, as a political party, we are always very, very interested and focused to inform the people of the country. We believe strongly in informing the citizens of this country on all topics and fields. And of course, in this case, because we do believe in educating the people of this country, I decided today to have a special invitee to be with us in this program, in the name of a colleague mine, actually, of Sint Maarten Medical Center, being the very known urologist, Dr. Diego Ramos. Dr. Diego Ramos, welcome to our program.
Thank you, Dr. Marcelina. It's an honor to me to be here. I am happy because we are going to share this minute to talk about prostate cancer, about the situation in the urology department, what we can help the population here in Sint Maarten, what we can do. What is the best way of line if you want to see the urologist? There are plenty.
We have plenty of topics to discuss.
Yes.
Right?
Yes. Mm-hmm.
Okay. Dr. Ramos, you have been here in Sint Maarten since 5 years ago. We started with urology on the island. Before that, there was Dr. Asin, that was he was a combined surgeon urologist, but he had so much work that he could not develop the urology as professionals as you, because of course you come with the solely focus to try to enhance the service and the department of urology as such for country Sint Maarten, what we of Sint Maarten Medical Center and of course the population of Sint Maarten are very, very happy with. So in principle you started here 5 years ago, and before that you were living in Venezuela. Dr. Ramos, the people of Sint Maarten would know you, some would not, and I think it's a great moment for us to make use of this opportunity for you to just use your biography as a background context for you to introduce yourself to the people of Sint Maarten once more.
Sure. I born in Venezuela. I was educated in the Los Andes University in Mérida, and then I did my surgical and my urological training in the Central University in the capital in Caracas. And then I did my private practice for 17 years in Margarita Island. And then I decided to come to Sint Maarten because I know that you have the deficiency in the urology, no urology.
Yeah, there was no
And we had to
urology.
fly out all the patients, even for simple situation. And then Dr. Holiday gave me the opportunity to come to work here in Sint Maarten. And now I have 5 years. And I received my first test in Sint Maarten a month after because I arrived in the first week of August.
Of 2010?
17, and then a
2007.
month after we have Irma here. No.
Wow, so you had immediately
Yeah,
a good encounter with the reality of Sint Maarten.
Yes. Well, it was
But
too
Sint
much.
Maarten has other great dimensions except hurricanes.
Mhm.
I think Sint Maarten is a beautiful country to live in also.
Yes. If we don't have a hurricane, it's okay. It's perfect.
Dr. Ramos,
Mhm.
so now you are since 2017, you are the urologist here in Sint Maarten. And by now, because there is so much work in the urology department, you have even a colleague, a second urologist working with you in the name of Dr. Rojas.
Rojas.
Exactly? And
Yes.
Dr. Rojas is also from
Venezuela.
Okay, so Dr. Ramos, you have to tell us, when you started here with urology, actually you had to start, as we say, from scratch. There was
Yes.
not much,
Uh-huh.
actually, when we speak about the specialization of urology as such. I think you had to start by the beginning to set up the whole department. Tell us a little how that went.
No, it's a fresh beginning because I decide what I can do. I bring my own equipment in the beginning, but after like 6 months, the hospital was sure that I'm supposed to stay. They test me, and they bought all the equipment that I want. But now we have, for example, in the hospital we have the urodynamic machine to evaluate bladder dysfunction, urine incontinence, overactive bladder. There are several pathology, interstitial cystitis. We can do the evaluation of the patient in the clinic. We have the tower and the cystoscopy equipment to do the evaluation of the bladder. If the patient is suspicious of bladder cancer, we can evaluate the patient. Now in the hospital, we have the MRI machine, because in the criteria to do, for example, to be sure if the patient is suspicious of prostate cancer or not, is a combination between the PSA, the blood test,
Yes.
and the MRI. And we have the advantage, we have a CT machine in the hospital, and in the operating room we have the laser equipment to perform the endoscopic surgery of the kidney stone. We have flexible scope. We don't need to perform open surgeries.
Okay.
No, I'm very happy with the equipment that we have.
So actually, Dr. Ramos, if I listen to you, but of course I know it, working with you every day, but I think with a program like this that we also use from the URSM to inform the people about what is going on in Sint Maarten, what are the possibilities, what can, for example, a hospital in Sint Maarten offer you in service. And if I hear already about all the instruments and options and possibilities that you have to do your diagnostics, to do your work, and not only to diagnose diseases, but also to treat diseases, I think there is a huge progress that has been made in the last 5 years here in Sint Maarten. You spoke about a few technical instruments, and I like to educate the people.
Okay.
Let's talk about the cystoscopy. The cystoscopy, I know the cysto is bladder, the scopy is look.
Yes.
So what is a cystoscopy? It's actually a camera that you go in the bladder with.
Yes, we have now the rigid and the flexible scope.
Yes.
And we do it in the office with local anesthesia.
You can do it in your office.
Yes, we do it in the office.
So I just sit in your waiting room, go in, and you can be in my bladder.
Yes, in
Wow.
few minutes, but we give the time first to get to active the anesthesia,
Of
the
course,
IFE.
of course.
And we can, for example, I have 3 days ago a patient with a macroscopic hematuria for a year. The patient,
Yeah. What is hematuria? That
the
is
blood in the
urine.
urine.
Yes.
And then one time we did the ultrasound, we saw the tumor by the ultrasound, and in the next 15 minutes we did a cystoscopy and we confirmed the diagnostic.
Okay, and can you at that particular moment take a sample from the tumor that you're seeing with your cystoscope to take a piece of the material of the tumor to send for pathology analysis and to analyze the cells to say to the patient, this is benign or this is cancerous or malignant as we call it. It can be malignant or benign. Is that an option for you to do the biopsy immediately in your office too with a cystoscope, or you have to plan it?
No, it's possible to take a piece, but the issue is if you take a piece, it's going to be painful because the anesthesia is in the urethra, not in the bladder.
And what is the urethra? That is the pipe between your bladder and going outside to the penis, for example.
Correct. Okay. And the second issue, if you take a sample in the bladder, you take a piece, but when you take a piece, it can bleed.
Yes.
So it's better to do it if you're gonna do a biopsy. It's better if a bladder biopsy. It's better to do it in the operating room to take a good sample to make a good sample.
Actually, what you do is the diagnostics, the necessary diagnostics you do in your office, and additional actions that has to be taken. For example, if you see in your office that there is a tumor in the bladder, you can organize for the patient to go to the operating room, and then you can do the biopsy in the operating room.
And the advantage also is because we have the monitor and the patient is awake, only with the local anesthesia, the patient can see what we are seeing.
Yes.
The patient can see, yes, I have a tumor, I saw it.
Yeah, the patient can see it itself.
Yes.
While you're looking, you can put the screen in a way that the patient can follow the camera with you.
Correct.
And see what you are seeing, actually.
Yes.
It facilitates actually also for the patient to understand later when you're explaining the patient, because he or she saw it with her or his own eyes.
Yes, because it's, like you said, it's education, and you can educate the patient at the same. Yes.
Fantastic. Dr. Rojas, one thing that we have gotten recently in our hospital that helps us enormously is the MRI machine. In the past, we used to send patients to the French side to do MRIs, and now we have a magnetic resonance imaging. That is actually where it stands for, this MRI, and actually it's a specific department that we can do MRIs nowadays. A lot of people think that as long as you do an MRI, you're okay, but people forget that it's not a treatment, it's just making images, pictures. In your specific field from urology, what are the indications as a urologist for you to say, I would like to pass this patient through the MRI to get some additional images? What are indications for a patient to do an MRI by you?
No, it's important because, for example, in the past, like 5 years ago, to do a diagnostic about prostate cancer, you use only the PSA, the blood test, and the finger, the digital rectal exam.
Yes.
So if you have a...
That is what every man are very scared of, that you're going to feel them from behind, as we say. Yes.
No, I have some friends, and they ask me why, if we have a blood test, if we have a CT, if we have a MRI, why you need to use the finger?
Yes.
Right? I don't want the finger. That's it. That's what they say.
I don't like that idea. But okay, it's part of it. Perhaps it's a good moment too to explain the males here in Sint Maarten about this mysterious examination with the finger to get an impression about your prostate. I think it's a great momentum to get this out of the taboo atmosphere and just explain the men in Sint Maarten that they should not be afraid. Just explain the whole procedure. What is it actually, and what are you feeling, and what do you want to feel, or what do you don't want to feel? Explain the people of Sint Maarten.
Sure. Because what happened, we're supposed to start this prostate cancer screening.
Yes.
You need to know first your family history. If you have a family history, for example, in the mother's side, breast cancer or prostate cancer or for both sides, father's side or mother's side, you need to be aware that you have more risk because you can have a BRCA mutation and you can have a a tendency, if you have the mutation, to have a earlier prostate cancer.
Yes.
If you have a family hereditary tendency in your family, you need to start with the prostate screening when you arrive the 40 years old. If you don't have a family history, you can do the first physical exam when you become a 45 years old. Okay, what it means when this is a different system in my country. If the patient want to see the urology, you go one time to the urology office and make the appointment. In this system, it's okay. You go first to the family doctor. The family doctor is going to order the blood test, the PSA total and free, and then you can request the approval of the family doctor to come to see me. Because almost all the patient has SZB.
A lot of patients are SZV insured, but actually all patients, independent from insurance, actually should have the accessibility to pass to your office.
Sure. We are open to receive all the patients.
Yes.
My nurse can give the appointment in a week time. It's not a problem.
Okay. So a person comes to you. I asked you just now to elaborate a little on the digital, the finger test that all men in Sint Maarten are very scared of. I just asked you if you can explain the gentleman's
Sure.
what that is exactly, and why do you have to do that, and what are you feeling? What is the whole intention of this test?
When you have if you're older than 45, we do the digital rectal exam. What it means? We are going to place the finger in the anus,
yes,
and then the prostate is just right there. It's very close to the orifice, and we're going to touch. We're supposed to feel like at the tip of the nose.
Yes.
Soft in the beginning and then a little harder.
Yes.
And the prostate have two sides, the left side and the right side, and both supposed to be symmetric.
Yes.
Supposed to be the same size, the same consistency. Why we use the finger? Because sometimes you can have a normal PSA, but you can have an abnormal finding during the physical exam. You can have a lump, a nodule.
Yes,
right, and and if we find this, even if the MRI is normal, and even if the PSA is normal, we can decide if the patient need to do the second step to proceed with a prostate biopsy.
Okay. So what you look for is actually when you go with your finger in, is that you're going to look first for the location where the prostate is, and you're going to pay attention to the surface. If it's symmetrically in both sides, because as you explained, the people of Sint Maarten, the prostate is actually, it has two lobes, one on the left side, one on the right side. So you're trying to get an impression with your finger while you're feeling if the surface is smooth or if it's irregular, or if there is a difference between the relief of the lobe on the right side compared to the left side. Or, for example, if it's in specific spots, extremely painful in sensation for the patient.
Could be.
And you're also going to get an impression about the size of a prostate.
Yes.
Okay, Dr. Ramos, we're talking about the size of a prostate. Everybody's talking about this prostate the whole day. Of course, as a doctor, I know the answers, but that's why I have you here in the program to explain to people, because I do believe that the people should be well informed about their health too. What is actually a size of a prostate?
The prostate size is 20 cc. It's like a, how is it, like a nut?
Yes,
a chestnut. A chestnut.
Yes, it's like a ping pong ball, or
yes, like a ping pong ball. It's okay.
It's approximately like a ping pong ball.
Yes, a normal prostate in a 20 years old patient is 20 cc.
20.
Yes, if you are older, the prostate is supposed to grow, not too much.
Yes.
For example, if you are 40 years old, you can have a prostate slight bigger. Could be 30, could be 40. But what is the most important? It's not only important the size. The most important, if you have a good urine stream, we have the machine to measure the urine stream in the office.
How strong and stable the stream is.
Yes, because when the patient comes to the office, I ask the patient, "You pee good?" "Yes, I pee good." "Okay, go outside, drink water, and when you have the bladder full, come and pee in the machine."
Okay.
And you can see how the reality
is
not all the time is a good urine stream.
Okay, Dr. Ramos, I'm very happy that you're touch basing on this urinating good, as we say. So you ask me as a doctor, okay, are you urinating okay? And of course I say, yes, doctor, for years I'm urinating the way I am doing it. And then actually what you do is you give us water to drink and you tell, okay, go sit outside, leave the bladder fill first. And then you're going to actually urinate in front of you that you can measure it actually.
Well, we have some patients have a shame. We have a special room separate.
Of course.
No, but we can see and even we can hear what it is, and the machine is going to make a beautiful graphic, and we can analyze, and then we measure how much the patient left inside
the bladder.
In the bladder, inside of the bladder.
With an echo. With
the echo, yes, we have the ultrasound machine in the office.
Okay. Dr. Ramos, your question to a gentleman in the office is, sir, are you urinating good? And the answer is yes. What for you is a good urination? When should I worry if something is wrong the way I'm urinating? Explain to people what is good and what should be a sign to look for a doctor, for example, in this case, the urologist. Explain me what is a good urination and what is not a good urination.
The patient is supposed to pee during the day 4 or 5 times.
Yes.
The patient is supposed to have a mixture volume about 400 cc.
What is 400 cc? It's about a cup, a good cup of
a little bigger, a little bigger.
So let's put 1.5 cup.
Like a half an. Well, a normal cup is 250 cc.
So let's put it 1.5 for 2 cups.
Yes.
That is a normal volume to pee at to urinate at one time.
Yes. There's a patient supposed to pee in less than 30 seconds. Okay, empty the bladder totally in less than
30 seconds.
30 seconds, no more. And the
so if I'm going to the 40 seconds, that means something is wrong.
It's slow. You can have an obstruction.
Yes. So that means that the prostate is a little enlarged, for example.
Yes, usually yes.
Okay.
And the last one is the speed. The machine have the capacity to measure the speed is 20 ml per second, and you can see the graphic, and you combine the speed, the post-voiding, the residual urine inside of the bladder, the capacity, and then we combine all, and we can say you don't have problem with your prostate. Your prostate is enlarged, but you pee good. You don't need a surgery in this moment. If you talk about obstruction, and then we combine with the PSA to see if the patient is suspicious of prostate cancer. If the PSA, the normal value is supposed to be lower than 4. Okay.
The value of
the PSA, the total PSA, 4 nanogram per ml.
Yes.
In the lab, they give you your value, and the normal range
is 4 approximately.
Lower than 4.
Yeah.
Lower than 4.
Until 4. Let's put it that way.
Yes.
Okay.
And if the patient have a PSA higher than 4, we combine with the free PSA.
Okay.
There is a second blood test in combination.
With
always,
the PSA.
Yes. And if the ratio between the total and the free is less than 20, the patient is suspicious of prostate cancer.
Okay.
And that's the new advantage that we have now. We have the MRI machine, and now in the guidelines, we use the MRI first. We don't perform the prostate biopsy without an MRI.
So we do the MRI first?
First.
And if there's any indication, then we combine with follow-up the biopsy.
Yes.
Oh,
if the MRI is say that the patient is suspicious of prostate cancer, and we have one more advantage. When we do the MRI, we can say if the cancer is localized. The MRI has the capacity to precise if the cancer is in contact with the capsule, with the outside, with the cortex, like a cortex, with the outside of the prostate. If you have a lymph node positive, you can see this disease metastasize to the lymph node.
It's spread. Metastasis means that it's spreading.
Correct.
Yes. Okay.
And you can decide if the best option for the patient is the biopsy is positive, if the patient needs a surgery, or he can go to radiation therapy, or can be a watchful waiting. Depend on
That's
what.
interesting. Ladies and gentlemen, time is flying on us. We, as you realize, we are having here a very interesting discussion with the urologist, Dr. Ramos, that works with me in the Sint Maarten Medical Center. And as you know, the URSM is a political movement, and as you see, we are using the time from the URSM, the Unified Resilience Sint Maarten movement, in the program name You Are Sint Maarten, to inform people, because we do believe that education, informing, educating the people of Sint Maarten is primordial, is important for a great evolution of a country. And that's why the URSM is using this program not to attack politicians, not to criticize the whole day. No, we are using this program also to discuss current or issues that could be of value for individuals in this community. And that's why today the URSM decided to invite a professional, a urologist, to talk about common issues that, especially what we did till now, is discuss, for example, the prostate abnormalities that can present in the males. As I said, time is running on us. We are going to take a small break, and we will be back in a few minutes. Dear people of Sint Maarten, once more good evening. Welcome to the second half of our radio program, You Are Sint Maarten. As you know, today we have a special invitee with us in our program in the name of Dr. Ramos. Dr. Ramos, as we said in the first half of our program, is the urologist working in the Sint Maarten Medical Center. And as you know, the URSM is organizing this You Are Sint Maarten radio program, and in tradition, you would expect that the URSM will always talk about politics and use this momentum to criticize other political parties and to criticize persons and to use the crap mentality. Absolutely not. As I always say, the URSM is a political movement that wants to change the whole political climate of country Sint Maarten, and especially the URSM is a political movement that wants to have a positive contribution to the development of this young country since 10-10-10. And the URSM is very focused on education and also very focused on informing the people of this country. And we do believe that a well-educated populace, people that are well-informed, will have a better contribution to the evolution of their country. Today, as I said, we have Dr. Ramos, the urologist, with us. Dr. Ramos, once more welcome to the second half of our radio program. Dr. Ramos, we elaborated on the prostate, and then I have a few topics more to touch base with you on. Coming back to what we discussed already about this prostate, let's go a little in the situation of country Sint Maarten. Can you give us an impression about how many cases of prostate cancer we have, new cases on a year basis in this country?
Well, really, if I compare my practice in Venezuela and my practice here in Sint Maarten, if I have 10 patients in Venezuela, maybe two of these 10 can be prostate cancer. Here's the opposite. My clinic, my daily work, 80% of my patients are prostate cancer.
So we have a very high incidence of prostate cancer in this community. Dr. Ramos, is this high incidence of prostate cancer or prevalence then that it exists in our community? Mm-hmm. Is it at the first place age-related?
The age-related, yes, because if you become older, you have more chance to have a prostate cancer.
So if I'm above the 60, that means I have more chance to get prostate cancer than if I'm above the 40?
Yes.
Okay.
Yes.
So age plays a major role in the initiation of prostate cancer. A second one, Dr. Ramos, that I was always questioning, seeing the high incidence of prostate cancer in Sint Maarten. Is it related to the race of humankind, the prostate cancer? For example, does it comes more in colored people compared to the white populace?
Yes, it's true. It's true.
So the dark skin complexity people, they have a higher chance of developing
prostate cancer.
prostate
Yes,
cancer.
100% sure.
That, and especially in Sint Maarten, we have a very dark, complex populace.
Mm-hmm.
You see an evidently higher incidence of prostate cancer.
You know, they try to relate it with the pesticide
Yes.
that was used, because I saw it in Martinique.
Yes.
I saw it, but in the United States, it's the same numbers. Right? They are not in contact with the pesticide. The African American have a higher chance to have a prostate cancer. That's true.
Compared to the white populace.
Yes.
Afro-Americans has a
Yes.
higher. And you think it's 3 times higher, 4 times higher?
The 4 times higher.
4 times higher.
Yes,
compared
and
to-
if you have a family member with history of prostate cancer, you have 8 times higher risk to have a prostate cancer.
So the risk factors are, Dr. Ramos, the higher the age, that's one, the more chance to develop prostate cancer. The Afro-American race is the second one.
Yes.
And the third one is?
The third one, to be honest with you, is not the diet, is not the sex, is not if you are diabetic or not. The higher risk is the patient doesn't come to check the prostate. That's the higher.
That is your frustration, actually,
Yes,
that people
sure.
come too late.
You know, when I arrived here in St. Martin 5 years ago, they give me a pile of paper like this. Dr. Ramos, these are your 50 first patient one time.
Wow, impressive.
Pending to be
be
evaluated, to be seen. I did 4 prostate biopsy per week during the first 6 months. And,
So-
and almost all was prostate cancer.
Oh,
and I said
horrible.
in my knowledge, after 5 years, I said we have the situation under control.
Yes.
Few days ago, I received a patient with a PSA 28,000.
That's too high.
No, it's too high. So even, and I asked the patient, "What happened with you? Why you didn't come?" Because I was feeling good. He came because he had developed a urine retention. But the issue is, the prostate cancer in the beginning doesn't have symptoms.
Yes, that's
Doesn't
the
you don't
problem.
have pain.
No.
You don't have pain in the body. You're not gonna have blood in the urine. Maybe the urine stream is gonna be slow, but could be because the prostate is enlarged, not
Not
specific.
being cancerous. Yes. So actually it can be, as we call it, a silent killer.
Yes.
So the moment you start to get symptoms and signs, it can be already in an advanced stage.
Yes, that's the
And
issue.
that is the problem. And that's why you, Dr. Ramos, are always again propagating to just go and do the routine checks by the family doctor or by you, or do a routine PSA test.
Once a year, do
Yes.
it once a year.
Okay, Dr. Ramos, this digital test that males don't like, that you go with your finger through the anus to feel the prostate. How many times a year you think males above the 45 years should do that?
Once a year.
Once a year.
Once a
Okay.
year, and 1 PSA per year.
Yes, okay. You want the digital, the finger test once a year, and you want also once a year
The
a
blood,
PSA
the
test.
PSA test.
And you
Correct.
want only the PSA, or you want the second test with the PSA?
No, both. Total and free. Total and free,
The-
both.
They call the total PSA and the free PSA. These
Correct.
are 2 separate requests on the lab form that people should put attention to, because sometimes you go to the doctor, he just puts a PSA free or PSA total. No, you have, as Dr. Ramos say, you have to do both tests
both.
to make sure that the combination can be interpreted as being too high or average or a normal result.
And the second issue that I saw when I arrived, of course, you didn't have a urology here in the past, but then you send the patient abroad.
Yes.
And the patient received a good treatment,
Yeah.
but the patient didn't do the follow-up.
Yes.
You can use after a radiation therapy or after a surgery, you need a follow-up for 5 years.
Yes.
To be sure, after the surgery or the radiation therapy, we say to the patient, you are cancer-free,
Yes.
but you are not cured. You need to continue with the follow-up because you can have a recurrency in the cancer. So what was the issue that I saw? That the patient did 1 year of follow-up, and then the patient, in his mind, was okay, and the insurance doesn't have the capacity to send abroad every 3 months a patient to be seen in the urology in Curacao.
Yes. Okay.
Now we have the situation under control.
Yeah.
Even if we don't have the capacity to do the treatment here, we don't have radiation therapy, for example, in Sint Maarten.
Mhm.
We do the follow-up here. We don't need to send the patient abroad to check the PSA.
Mhm. The frequency of having sex or the incident that you had venereal disease, does that contribute to a higher risk of having prostate cancer? Because
No,
you
no,
hear
no.
that on the street. That people say that if you had once a venereal disease, a sexual transmitted disease, that you have a higher risk to get prostate cancer.
No,
Is that true or is that not true?
No, it's not true. It's not related. No,
And the frequency of having sex does not have any reflection on the incidence of prostate cancer.
no. You can have a high frequency or a low frequency.
It doesn't
It's
contribute
not
anything.
going to
Well, these are
modify.
discussions that you
Sure,
always
sure,
hear.
sure,
You
sure,
always
sure,
hear it
sure,
on the
sure.
street, a man talking about it. And I think these are the moments that we can inform the public about the facts of this prostate cancer by males.
And the second issue that I can see here in the man is the erectile dysfunction too.
Yes.
No, because we have more diabetic patient, more hypertensive patient. Sometimes the control is not from the beginning, and when you have these two elements, the diabetes and the hypertension at the same time, you have a higher incidence of erectile dysfunction.
Erectile dysfunction. So
Yes.
that is also, of course, one of the other topics that you treat. And it's, of course, a sensitive topic to talk about. But this problem, this erectile dysfunction, is one of the problems too that you can do something for the males, right?
Sure, because the patient want to know if I know the medication is not covered by the insurance, but the patient are afraid sometimes to use it. They want to use it, but they are afraid because they can have a heart condition. They're afraid if they're going to pass if they use the medication. And we advise the patient, we evaluate the patient, we explain the different medication that we have in the market, the dose, how he's supposed to use it. And then the patient can decide. And even if the patient is not sure, we can send the patient to be evaluated by the cardiology first to see if the patient is in good condition to start with the medication.
Yes.
The other topic the pathology that I see here in St. Maarten is the overactive bladder.
Overactive bladder.
Oof.
Explain us what that overactive bladder is, Dr. Ramos.
We have a patient with, for example, with you're supposed to have a bladder capacity of 500. When you have an overactive bladder, there is not a specific reason. You can develop the overactive bladder any time of your life, and you start to decrease in the capacity to hold the urine. And the patient need to go to the bathroom every half an hour, or every hour. And the patient cannot sleep in the night because they have this strong desire to go.
And it's by females and males,
Females and males.
both sides.
Both sides.
Yeah,
Both
yeah.
sides. It's not only
By males.
by males.
Dr. Ramos, you're talking about other abnormalities in your specialization. People do believe when we talk about the urologist, most of the time you always think it's men with a prostate issue that comes to you. But actually, you are a specialization that sees a lot of females too. I would like you to just elaborate actually on all the abnormalities that your specialty pays attention to as being your specialization. Explain to people of Sint Maarten a little what actually the urology covers.
No, we cover, for example, if we talk about kidney, we cover the kidney stone, we cover the kidney cancer, we cover the malformation that the patient can have in the kidney. If we go into the bladder, we cover the bladder tumor, we cover the urine infection, we cover the bladder stone, the overactive bladder, the prolapse.
Prolapse is also one of them.
Yes.
The prolapse is actually a topic on its own also.
Yes,
here in
yes,
Sint
yes.
Maarten, yes. And further, by prostate level, you discussed matters concerning the kidney. You went a level lower. You went to the bladder. And what more do you do? If we go, for example, to the male, let's go down further. What more do you do? We deal up with the erectile dysfunction. Yes.
We have a lot of Peyronie disease here.
See.
A peritonitis. The
Yes.
peritonitis means that the patient develop a scar in the corpus cavernosus, in the inside of the penis, and the patient develop a curve in the penis.
Yeah, it transforms actually the form of the penis, and especially in erection position, you can see that very good.
Yes.
I'm a surgeon, of course, I know what you're talking about. But it's nice for the people to know that this, they call it morbus peroni. Huh? It gives actually by erection a deformation
Yeah,
of the
the
penis.
patient have a pain during the erection, and they say, now doctor, I see the penis bend to one side.
Yes, it
and
curves to one side.
Yes, and the patient said, I cannot have sex, I cannot penetrate because the penis is too
Deformed.
curved, and
Yes, it doesn't work out.
they are surprised.
Yes. So further, you are all abnormalities on penis level, you treat too, but we also have by the male, the scrotum, with the testicles. There are a lot that you can say about that too.
Yes, we have the epididymis cyst, we have the hydrocele, we have the testicle cancer.
Yes.
Here, the rate in the African American is low, very low. It's weird to see
In comparison with the prostate, you see a high incidence of prostate cancer, but a low incidence of testicular
I
cancer.
can tell you the African American population have less incidence of kidney stone.
Less kidney stones.
Less. You can see it more in the Indian population, in the Latino population. Oof.
A lot of
When I arrive here, I bring my laser, I bring my scope. I say I'm gonna do kidney stone surgery every day.
It was a disappointment.
Yes, really, it was more focus. Really, the focus here is prostate, a big prostate with no cancer, or a prostate with cancer. But here, really,
Most of your pathology is the prostate.
Prostate.
Okay. Let's touch base now on the females, Dr. Ramos. Females, I see females sitting in your waiting room too. Let's elaborate a little on the variety of abnormalities that will make a female patient approach you. What are current common abnormalities, diseases by the female that would make them visit you?
Here we have more chronic UTI, chronic urinary infection.
Urinary infection?
Yes.
By the females?
By the females.
Yes.
The overactive bladder.
The overactive bladder that we spoke about.
And the urine incontinence, the incidence of urine incontinence in the African American population is low. It's low. It's more the overactive bladder than the urine incontinence. The Latino female had a lot of urine incontinence.
Yes.
They have prolapse. Here
you do not see that by the
No, it's weird. It's weird.
Yes, so you see it's a little race related to the abnormalities that can present.
That I can tell you the overactive bladder is higher. You can see per week 2 to 3 new patients.
Yeah, but Dr. Ramos, you every time again come on this topic of the overactive bladder. Give me one reason why somebody could get an overactive bladder. Do you have a...
No, there's not a specific... The patient start, for example, the complaint, doctor, I cannot sleep. I have a female taxi driver. He said, doctor, I cannot work because I have passenger in my back seat, and I have to stop in the middle of the road, and I have to run to the bathroom. Hey, where you going? Hey, and then, or the patient said, I have to sleep in the toilet because it's not I'm gonna wet the bed. I cannot
and
rest.
You have good medication to help these.
Yes, and we have the advantage now that we have medication. The Besicera and Mirabegron, with almost all the patients, we can have the capacity to control the overactive bladder. And if even using the medication it doesn't work, we have the capacity to use Botox. The Botox that we use in the face for the female, we use it in the bladder
wall,
to relax the bladder wall. Relax the bladder wall and decrease the urge sensation. And it worked for 6 months. You're going to be under control. This is to improve the quality of life, of
course.
Yes.
Every time you have to go to the toilet, it's going to be very invalidating for your social life, of course.
Yes.
Okay.
And we have this medication here. We have the tools to help the patient here.
Yes.
No, I'm very happy with the development that we have in our services.
Yes. If I listen to you, Dr. Ramos, in 5 years' time, an enormous positive evolution took place in the field of urology for Sint Maarten. For that, of course, as a leader of a political movement and having my great love and commitment for my country, of course, in the name of the people of Sint Maarten, I would like to thank you for everything that you're doing on the field of urology for the males and also for the females for country Sint Maarten. We had a very interesting discussion with each other. Dr. Ramos, I have one more question for you, Dr. Ramos. We are working towards a new hospital for country Sint Maarten. That is one of my dreams before I finalize my professional career in Sint Maarten, is to look back and look to a building, an organization, and say, this is what we have left behind for the next generation. That is what I would really want for my country. I dream about it, to have this for the next generation, for all here living in Sint Maarten. And I do believe if we all stay focused, we can realize, although there are a lot of hiccups, can realize this project for country Sint Maarten. And I have a last question for you. Would you like to see something extra for urology in our new hospital in the nearby future?
Yes.
Okay, tell me, Dr. Ramos, because maybe perhaps I will become the big leader of this country, and then I have to think back, what Dr. Ramos wants? Let me see how fast I can arrange that for the people of this country.
No, it's difficult. We have a lot of patients with erectile dysfunction.
Yes.
And we did for example, penile prosthesis surgery in the hospital, but SZB doesn't cover the penile prosthesis, and it's important in my point of view. But the patient want to continue with the sexual activity.
Yes.
It's not mean because you are too old. You reach 65, go home and rest.
Yes.
That's an important point. I think that the robot, the Da Vinci, in the future, because this is here now. It's here. We don't have it, but in the future maybe we can have it.
The robot surgery.
Yes, and
robot-assisted surgery.
Yes.
For the people of Sint Maarten would be a great development in the hospital.
Yes, and we have a laser to treat kidney stone, but I'm gonna push to bring the laser surgery to do prostate.
Okay, so you would like also to broaden the spectra of treatment of the prostate cancer with laser surgery?
No, the enlarged prostate with laser. The laser.
Yes.
The enlarged prostate with laser.
Sorry, yes, not the prostate cancer, but the prostate hypertrophy.
Yes. I don't know if we need a bigger population, or maybe if we combine all the service to have the radiation therapy here too.
Yes, and what I was thinking, Dr. Ramos, it's always not only about the big service that we have to provide to the people of this country, that is our priority, but also to look at possibilities to contribute to our local economy too. And for example, that we can become a center for some treatment for islands in the vicinity, and that will, of course, help us also with revenues to help our economy of Sint Maarten in a way that we can service the surrounding islands with, for example, the laser treatment for the large prostate. For example, in one day in our dream, perhaps it may become a reality that we will have that robot surgery too here in the new hospital. And if we can work seriously towards these types of extras in the healthcare, we can also sell it to the neighboring islands, and that also will increase the revenues for countries in Maarten.
We have of course, the SAVE anesthesia.
Yes.
But in my opinion, one of the biggest market that we have very easy to reach is Anguilla.
Of course.
The Anguilla Island is 20 minutes from us, and we have to increase the relation between Anguilla and us. That's
Of course. Dr. Ramos, don't give up the hope. There is a new leader coming up for country Sint Maarten in the name of Dr. Messelina with his URSM, and I am very progressive in my approach, and I like to think out of the box to put Sint Maarten on the card again and see if we can promote Sint Maarten and make it a leader country in the Caribbean. Unfortunately, we are nearing the end of our radio program, You Are Sint Maarten. We had a very interesting conversation today with Dr. Ramos, the urologist in the Sint Maarten Medical Center. Dr. Ramos, I want to give you for the last time the floor before we close. The floor is yours.
Well, when Dr. Rojas and me, we are open to see you. Okay. You can call the hospital 543-1111, yes. Extension 1307. I'm a nurse. It's open to receive the phone call and give the appointment. If you never check your prostate, come to see us and do the PSA. Go to your family doctor, and you're gonna see it's not too complicated. We're gonna open to see all the patients.
Fantastic. Okay. Ladies and gentlemen, as you have realized today again, the USM is presenting topics that are interesting and concern the people of this country. It's not always about politics. No, as we always said, the USM wants to touch base on general topics too that we do believe we have a responsibility in also to help and inform the people of this country. And today we chose to speak about health conditions on the field of urology with Dr. Ramos, and we are very grateful to Dr. Ramos that he took his time out to come and sit with us in our radio program. Dr. Ramos, once more, in the name of the people of this country, I would like to thank you for everything that you're doing for the country Sint Maarten. Ladies and gentlemen, thank you for being here with us today in our You Are Sint Maarten radio program. And I'm looking forward to have you back in our weekly radio program next week Wednesday from 6 to 7 p.m. on Radio Mix 94.7. Have a great evening.